Okay, welcome everyone. We are going to get started. We were just waiting a couple seconds to let everyone pour in, but for the sake of timing, I will go ahead and jump into it. Well, first of all, welcome everyone to our second Ocular Melanoma Patient and Caregiver Symposium Day 1. My name is Jasmine. I'm the Managing Director here at Save Your Skin, and I will introduce you to our host for today. But before I do want to go over a few quick Zoom housekeeping rules with you all. And I also want to thank you all for joining us today on this lovely Saturday. I hope the weather is good wherever you're joining us from. So first of all, today we do have a few presentations. We don't have a Q&A session. However, you can use the Q&A feature or the chat at the bottom of your screen to ask questions during the presentation. And Nigel and I will be addressing them tomorrow in the Q&A period / discussion period that we have. If for some reason we are unable to answer your question, so if it's specifically to one of the presenters, we will make sure to email you their response to your question, but please feel free to ask them during the presentation and our team here will make sure to collect them. I also want to note that we do have tech support on the line, that you should see them in the call. If you have any issues, please feel free to send them a message and they will be happy to help you out. So before we move on, I would like to quickly introduce Save Your Skin Foundation and Ocumel Canada. So Save Your Skin is a national patient-led non-for-profit dedicated to fighting melanomas, non-melanoma skin cancers, and ocular melanoma. We focus on education, advocacy, and support for all Canadians affected by skin cancers. We work to ensure equal, timely, and affordable access to treatment by engaging with public and private sectors, health policymakers, and drug approval bodies across Canada. So quick little note about Ocumel Canada. Ocumel Canada is an initiative by Save Your Skin, and it aims to raise awareness, improve treatments, and build a supportive community for those with ocular melanoma. We collaborate with global medical advisory boards and partner organizations to adopt international best practices to enhance outcomes for Canadian OM patients. This is a rare cancer and it poses unique challenges due to its low incidences, but in many provinces, services are limited or non-existent, making our mission crucial. So I want to say a big thank you to those that made the symposium possible, and they are our partners at Medicine, Immunocore, Castle Biosciences, Bristol Myers Squibb, Merck Canada, and Pfizer Canada. So that's going to be all for me for today. I will pass it on to Nigel, who will introduce himself and get everything started for us. Thank you so much.
Thank you, Jasmine. Greetings to everyone from Vancouver Island all the way across to Newfoundland. My name is Nigel Deacon, and I live in Victoria on Vancouver Island. Thank you so much for joining our second Canadian Ocular Melanoma Patient and Caregiver Symposium, a very proud moment for Save Your Skin Foundation and Ocumel Canada. We hope you will learn a lot from our 2 days of sessions about various aspects of this disease. I was diagnosed with ocular melanoma in June 2010. I had absolutely no symptoms and was diagnosed completely by accident. It was a big shock to me, as I'm sure it is to all patients. I asked at the time if my disease would be tracked by scanning and was told there was no point, as nothing could be done about it if it spread. I worked hard at not thinking anymore about it and getting on with my life. In March 2012, just under 2 years later, I had some inexplicable severe pain. I went to emergency where a CT scan revealed that the disease had indeed spread to several parts of my body. I was even more shocked to hear the same message again at that time. There's nothing to be done. Just make your arrangements. I'm a fighter, and no was not a good answer for me. I fought my way to several treatments through the next 4 years. And by some unexplained miracle, the disease went to sleep and has remained asleep 12 and a half years after diagnosis of metastatic disease. I've just been through scanning and am okay until March of next year. In the beginning, I did not know anyone with that disease. I looked hard, but I was alone. Online, I found some groups in the States that were organizing, and I built friendships with them. Several years later, that formed the basis for the creation of Ocumel Canada. I had, in the meantime, met the extraordinary Kathy Bernard, the legend of cutaneous melanoma in Canada. She could remember being in a very similar situation many years earlier. A revolution in treatments for cutaneous melanoma occurred between 2010 and 2015, but Kathy was well aware it still looked very different for ocular melanoma patients. We put our heads together, and Ocumel Canada officially emerged in January 2019. We had been doing the groundwork together for 2 years already. Much has happened since then. We're going to be hearing a lot about that positive change over the next 2 days. Before I introduce our first speaker, though, I'd like us to take a moment to remember an important person we lost this past year, Dr. Sue Johnson. In a moment, we will play a video from her husband, John Douglas. But first, I want to emphasize that this symposium is dedicated to her. We honor the exceptional work she accomplished and her generous donation to Ocumel Canada. Today, we celebrate her legacy. And let's have the video play now as John expresses it more beautifully than I ever could.
My name is John, and I was married to Sue Johnson for 37 years. I would like to express my thanks to the Save Your Skin Foundation for this opportunity to tell you a little bit about Sue and about her journey with cancer. And I do want to also express my thanks to the foundation for all the support that they provided during that journey. And I want to thank Dr. Butler and Princess Margaret Hospital for the wonderful care that they provided, as well as for the research that they're undertaking, which will hopefully lead to a cure for ocular melanoma. I want to say a few words about Sue and talk a little bit about her journey. 3.5 years ago, Sue discovered that her ocular melanoma had metastasized to other parts of her body. Even though she had lost an eye, it was too late for the removal of the eye to prevent the metastasizing. So for 3 years, until she died last April, she was living with this very difficult diagnosis, and I think it was quite a journey from various perspectives, as I suspect many of you know. Sue herself was very brave. At the same time, she was willing to be very vulnerable, and at many times she was pretty scared. So it was not always an easy journey, but for Sue, she had lived a pretty amazing and a very full and passionate life, and she continued to do so up until 3 weeks before she died. Really an up and down 3 years, but that she continued to work, do podcasts, do trainings, to write, and enjoy life as much as she could, walking in nature, doing some birding, even doing still some of her kayaking, and of course in the garden where she loved to potter. She loved her family, she loved her friends. She was a very passionate woman, not only in her personal life but about her work. She was a great mom, wonderful grandmother to our granddaughter. Oh gee, she was quite brilliant. Maybe that's a segue into her life's work, which was It started in a pub in England where she grew up watching different people interact in relationships and became fascinated with the dynamics of relationships and how people got into conflict, got out of conflict. And so she developed through her education and even beyond an amazing model of therapy known as emotionally focused therapy, which is now used all over the world. Probably the best model of, well, it is the best empirically validated model of couples therapy in the planet. Sue was a psychologist. She was a professor. She was a researcher. She was a presenter. And she was an author, very prolific author. She wrote many books, many chapters in books, probably hundreds of articles. And she made an amazing impact on the world of psychotherapy. The tributes that poured in after her death spoke volumes, hundreds and hundreds of tributes where people said that Sue had impacted their lives both professionally and personally, in a positive way, obviously. Sue was quite an amazing person and was acknowledged as such in her professional life, won several awards, and was very proud when she was given the Order of Canada. We all go through this journey, which is not easy, but fight the good fight. And in Sue's case, her life, both before and during the cancer, is a life that is certainly worthy of celebration. Thank you.
Once again, I want to thank John for that beautiful tribute to Sue. It was an honor for me to become her friend. And now, to start things off, I'm delighted to introduce Sherry Agriesti. Sherry is a proud Newfoundlander with 38 years of experience in the IT industry. She enjoys traveling abroad when she can, but spends most summer weekends at the RV park with her family trailer, often kayaking on the pond. While she used to be an avid curler, these days she enjoys cheering on the sport as a fan. Sherry is an active member of the OM community and dedicates her time to supporting newly diagnosed OMIs wherever she can. Sherry?
Hi, everyone. Sherry Agriesti here. I'm honored to have been invited to present here today. As was mentioned already, this is the second Canadian Patient and Caregiver Symposium focused on ocular melanoma, and it was very important to the organizers to make sure that the voice and perspective of people living with this disease was included. As you know, this is a rare cancer and it can be a lonely experience. So I'm honored to have been asked to kick off day one of the symposium by sharing my story as a person living with primary ocular melanoma. It may take me a few minutes because I've got 60 years to go through here, but hopefully you'll be patient. Just wanted to start at the beginning because my story starts before a lot of folks. A lot of folks started with changes in their vision and, a quick visit to an optometrist, which leads to a whole different place. But mine started back in Western Newfoundland where I grew up. My mother was legally blind, and because of her concerns, she started us, my sister and I, seeing an ophthalmologist. in my early teens. So I used to see them every year or two. And I moved to St. John's, Newfoundland later on to go to university. And it was at that time I was told that I had a nevus in the back of my right eye. At that, it was explained to me to be similar to a mole on your arm, and it was explained that, like a mole can turn to cancer, a nevus in the back of your eye can turn to cancer as well. My take on it at the time was, what are the chances of a mole turning to cancer? So I have to say, I wasn't very concerned about it. Now, this was pre-internet days when you could Google, what was going on. So I think I'm thankful for that, because I wasn't really concerned over the years. The nevus was stable for over 3 decades. So I went every year or two to see the ophthalmologist. And it was around age 53 when I at the first time when the ophthalmologist mentioned the change. So I went every year or so and had photographs and an ultrasound done, and they compared them. And funny story, back in the early days, my ophthalmologist used to take out there was no photography, so he'd just look in my eye and he'd take out a little cue card and he'd draw a picture of what the nevus looked like. And the following year, he'd look in my eye and he'd take out the card and compare the two. So that was a while back. So around age 53, I was told that there wasn't much change, is the way it was put to me. And I was a bit concerned at the time. And my ophthalmologist kind of increased the number of visits, or the frequency between the visits I had, for a little while. And then it seemed like there was nothing to be concerned about. So I went back to my regular non-worrying status. And sadly, I think we should have kept up those more frequent visits, because when I went back a year later, my around 2 millimeters nevus had bloomed into a melanoma. So it was around age 55 when I was told there was that significant change. And actually, at that time, I was by myself for my regular visits, so I didn't have anybody with me. And but again, there was nobody brought in with me. I had no family support. I was just told point blank that it looks like it's melanoma. And the doctor and I had discussed that in the previous time when there was a small change. And I had asked what would happen, and he had told me at the time, well, if it turned into something, you'd have to go to Princess Margaret Hospital for, I think he said, for diagnosis or something along those lines. So I may have Googled it at that time, but just a brief look at it. I didn't think much more of it. So when I was pre-diagnosed in November of 2019, of course, I went home that night and properly Googled it. That was after a few tears at the hospital by myself, and because I knew that there was definitely something up. And my doctor, when he also told me of a few other markers, but of course by that time I wasn't really listening. Once he said melanoma and Princess Margaret, I tuned out a little bit. So then the next was waiting for the Princess Margaret referral, and I have to say it was a time of a fair bit of stress and anxiety in my life. I remember the 12 long days it took for the ophthalmologist to send a referral letter. Meantime, I was on Princess Margaret's site and writing notes and trying to figure out if there was something I could do to move it along. And I may have showed up at the ophthalmologist's office once or twice and called a few times. So finally it did get sent, and I did get a quick response. So between November 20th, 2019 and December 17th, it's not a terribly long time. But I didn't know enough at the time. I assumed it was caught early, but again, you know, we all have our fears about, will we lose an eye, or, you know, what's the future going to look like? So at my visit at Princess Margaret, I was well taken care of course, and I was a little surprised that the tests they did were exactly the tests that I had done, you know, back in Newfoundland. So just the photos and the ultrasound, and that was enough for Dr. Krevna's team to tell me that they were, you know, 99% sure that it was melanoma. So there, what I find with some folks, there seems to be, you know, second opinions, and is it really a melanoma? But after, you know, after being watched for 30 odd years and plenty of time to have a look at it, I was pretty sure that that's what it was. And that day we went ahead and completed the pre-op test, and I signed the papers, and I was scheduled for my plaque therapy the first of the year. So just a little stat there in case anybody wants to compare to theirs. My tumor measured 3.44 millimeters high, and 10 and a half at the widest of the base measurements. Basically, it was on the inside, on the back corner of my eye. I had plaque surgery January 2nd. All went well, except I don't do well with the anesthesia, so that wasn't a pleasant experience for me. So I was quite happy that I booked to stay in the hospital at night. But once that first day was over, the next 6 days were pretty good, except for some fatigue. I was able to go out and walk around, do some shopping. You know, I wasn't in, other than a little bit of discomfort. It certainly wasn't too bad. I did have, actually, at the time of diagnosis, my children were 15 and 17 years old, and being January and snow in Newfoundland and getting back and forth to school, I actually asked my husband to stay home with the kids, and I had a friend that traveled with me. So I stayed in Princess Margaret Lodge, and I have to say she took good care of me, and it wasn't a terrible experience. The plaque was removed, of course, a week later, as they do in Princess Margaret, and I flew home the next day. After plaque removal, of course, you know, there's the blurriness and some double vision, those kinds of issues like most people have. I had a little bit of vertigo, and where the muscles were stretched straight down in my eye and to the left, it certainly didn't feel good for a while. But I bounced back fairly quickly and started driving and back to work around 2.5, 3 weeks later. So I'm thankful for that. And I didn't have, I was concerned about the double vision, of course, because that can be pretty hard. But that, other than I pointed out here on the slide, I had some lasting aversion to bright lights. I think a lot of us probably do. And driving at night in wet weather is an issue, but otherwise I can still drive, which I'm thankful for. And it took about a year for, now it might have happened before that, but it was about a year later when I was told that the tumor was indeed a non-entity, and I didn't have to worry about it as such. So I was pleased with that for sure. My ongoing surveillance, yeah, I just wanted to point out that I did have impact genetics biopsy during, or I had a biopsy during the plaque insertion surgery, and that was through impact genetics. I know there's another type of biopsy. This one, I got my results, I don't know, a few weeks later, And I actually did call and ask for a copy of my report, which I did receive at the time as well, or a little bit later actually. So I do have the paper copy. Mine showed isodicelmy 3, which I scratched my head at for a while, and but basically was told that it's technically the same outcomes as a monosomy 3 diagnosis, which put me at a little bit of a higher risk, or at a higher risk. But according to the report I received, I would say somewhere in the middle, not the best and not the most severe risk. Because of those biopsy results, Dr. Crema assigned me to a medical oncologist that we're going to hear from after my talk. So Dr. Butler from Princess Margaret Hospital then took me over from a surveillance perspective. So he guided my local medical team to arrange for yearly lung CTs and semi-annual blood work and liver and abdominal MRIs. Both the MRIs and the lung CT I get with and without contrast. I know that there's been some discussions on our Facebook group around what type of scans people are having and what ones are being recommended. And I think there's a fair bit of discrepancy across the country around that. I will note that the pandemic did cause some disruptions to my Toronto follow-ups, and I went up in one visit heavily masked and kept away from everybody, which was fairly stressful. So the following 2 visits, I actually went to Corner Brook, which is where I grew up. There's a doctor there who was a fellow under Dr. Crema's team. So I did go there for 2 visits, and then after, when the vaccines came out and I felt safer, I did return back to Toronto for my follow-ups. So I had, again, semi-annual trips to Toronto in the beginning, and once the tumor was deemed, stable, then Dr. Crema's team advised that I could just return for yearly visits. Most of my visits with Dr. Butler have been virtual to date, so they continued as they were. Also, I wanted to say that my local ophthalmologist was booking my my MRIs, my lung CTs, but that ophthalmologist moved away, and I got a new doctor, and then he decided to refer me to a local oncologist here. So now, and that local oncologist would book my scans. So now I have 3 oncologists, and I'm thankful for that. I'm hoping that I won't fully need all of them, but I do appreciate obviously their support. So, effects of radiation. My tumor was considered on the small side of medium, so I was hopeful that I would escape the radiation side effects that many have, but alas, it took a couple of years, and then the signs started to show. So it started with some cotton wool spots, and then some small bleeds in the macula, and after 3 years or so, I started having vision changes that that I could see, blurriness, and then some lines that weren't as straight as they used to be. And I went to the ophthalmologist, but I think with all these sight changes that happened, some improvements and some get worse. And then I do have a blind spot up here somewhere, which is where the tumor is. But I think what happens is there's so many little things that you're used to little changes, and you don't necessarily know which of the vision changes you should trigger a call to your ophthalmologist. I had some flashing lights and a few different things, and some of that settled down. But when I did go that very day, he said, "Yeah, we need to start, on the Avastin injections." And I remember he asked, "Do you want to have it now, or do you want to book something?" And I said, "No, let's do it. Let's do it now, because you don't want if you can save your sight, you want to do it." And funny story, my husband was in the room with me, and he can be a bit squeamish. And I said, "Now you'll have to turn your head, and you don't need to look." And next thing, he got up and he left the room completely. He couldn't even listen. So, anyway, but that's it. It was a funny moment in the end, right? So I received 4 or 5 Avastin shots, and there wasn't a lot of improvement. So I was switched over to Eylea. Of course, Eylea comes with a high cost, but luckily my ophthalmological team managed to get that covered for me, so I was very thankful for that. And the monthly shots, then they managed to lengthen the time or the interval between shots, and I'm up to 6 or 7 or 8 weeks in between. I had one laser treatment early on in that game. And I did want to say I think they should warn you when you're having the shots that this, of the things that can happen. Because I did have one day where I'm not sure exactly what happened, if they hit a nerve or something, and it was a bit of a weird event. And another where I've only had one where I've had like a little blood, a little bruise or something. So, but I think they should prepare you for those things. But most every other shot, I've only had 2 where there was anything odd. Every other shot was just a bit of discomfort. It wasn't anything terrible. And my vision is, it didn't go back to pre-plaque or anything like that, but it still rates. I can read 20, sort of 20/20. They still mark me in the 20/20 zone. It's a little less sharp, but it's better than I expected, so I'm pretty pleased with that. And I noted here that recently I've been having fun with floaters and flashes. So one day, I think a number of floaters must have released from the back of my eye, and initially I found it fairly bad because they were spinning and moving, and a little bit of vertigo, and I was thrown off for a bit, but they started to settle again. And it's funny how the brain will get used to seeing differently. So they've settled. The doctor did indicate it could take a year for everything to settle, and maybe I'll just get more. It's hard to say. Some are injection related because you're getting liquids added to your eye volume. So, but I will say I think it was completely worth it in my case, because my vision is being kept at a good standing. So I wanted to just clue up here with a few things to celebrate. I've had clear scans to date, and of course, every time you hear NED, it's a big celebration. NED being no evidence of disease. My next scans are coming up soon, so we will see where they go, but I am hopeful. I've had 2 prescription changes in my glasses. I wore contacts before plaque surgery, and I've had 2 prescription changes since then, so over 5 years. But my recent one, then the near vision, I wear bifocals, the near vision actually improved, which I kind of just laughed at, because that, it's awesome. But perhaps because of the injections, I'm not really sure, but I will take it, definitely. Other things to celebrate, Ocumel Canada and Save Your Skin Foundation are providing financial support for ocular melanoma patients to get access to appointments and treatments across Canada. It's a vast country, and flying and hotels can be quite expensive. And so very pleased with that. And we had a successful Miles for Melanoma fundraising event this year. So I appreciate everybody who could contribute to that. Also on the Facebook group side, I just wanted to point out that when I had plaque surgery, I couldn't find much in the way of a group. I think I didn't join any because I probably saw the ones from the US, and I went into it without the information I think I really needed beforehand. I certainly could have used a bit of support. So I was very pleased to find the Facebook group a little while later. And what I'm seeing now is I'm seeing more connections between ocular melanoma patients and caregivers, and then information being passed back and forth around, you know, how folks are faring after various procedures, and, you know, comparing surveillance and treatments. Also, I had to give Nigel a high five. Again, he started up he was the catalyst behind Ocumel Canada and started the Facebook group. And recently there were 2 patients that were going to have plaque surgery the next day, and they both found themselves on the Facebook group and figured out that they were both in Princess Margaret Lodge and were able to connect, you know, the night before they had surgery, which I think is very valuable, you know, to have that support and someone to speak with. So I thought that was fantastic. And recently here in St. John's, five of us went out for supper and had our first ever meet and greet. And if I've missed anybody in St. John's, just let me know. I don't have you know, a list of everybody, but if there's anybody who wants to connect from St. John's to get together or just chat, and again across the country for that matter, I can chat with anybody. So if anybody wants to reach out, please do. And just want to leave you with a bit of hope for the future. You know, I feel that, you know, there's more support now for ocular melanoma patients. Funny, with the pandemic, it did a lot of bad things, but I think it did some good things in bringing more of the symposiums, webinars, information and connections online, so that people in remote areas don't have to feel as, you know, as alone, because we all know, in my opinion anyway, the people that understand what you're going through are other ocular melanoma patients. It's difficult for your family to understand on times, unless you're living it, family and friends. Also, I wanted to say, you know, there's more data sharing on patient data. There's registries of data. There's also, you know, oncologists and researchers working together pretty much across the planet to you know, about ocular melanoma and, you know, the treatments. Sorry, need a sip. There's been more research in recent years, which has led to better treatments that we know of, like Kimtrack and other clinical trials that are being used to treat metastatic disease. There's also clinical trials being used for, you know, try to reduce tumor size before primary, before plaque radiation, before primary tumor treatment. Also, I think, you know, when everybody Googles the statistics online, it's disheartening, but I'm expecting with some of the recent news that those statistics will be improving in years to come. Also want to point out technological advances. This is kind of just my opinion, of course. You know, AI it's getting a bad rap for some things, but I think that perhaps it can help with understanding diseases and perhaps with better treatments in the future. So I'd like to thank you. I've got just some contact info there. I can be found on Messenger, and we've got the Ocumel Canada website and saveyourskin.ca email address. It is now my honor to introduce our next speaker, Dr. Marcus Butler, who will be presenting on metastatic disease and give an update on current state of ocular melanoma in the healthcare landscape. Dr. Butler recorded his presentation for us and was able to do a Q&A session with some questions that we collected prior to today. Dr. Butler is a medical oncologist and the Medical Oncology, Melanoma, and Skin Oncology Site Lead at the Princess Margaret Cancer Center. He is a physician investigator with an interest in the translational development of immune-based therapies for cancer patients. He received his MD from Yale University in New Haven, Connecticut, and trained in internal medicine at Johns Hopkins Hospital, Baltimore, and hematology oncology at the Dana-Farber Cancer Institute in Boston. After serving on the Dana-Farber staff, he joined the Department of Medical Oncology and Hematology at the Princess Margaret Cancer Center in 2012. Dr. Butler is the Medical Oncology Disease Site Lead for melanoma and skin cancers at Princess Margaret and is an Associate Professor of Medicine at the University of Toronto. He is the Clinical Director for the Immune Monitoring Team at the Princess Margaret Cancer Center, where he focuses on the immunologic impact of anti-cancer immunotherapies. Dr. Butler has been a great resource and a friend to Save Your Skin Foundation for many years, and we are so pleased that he is the co-lead of Ocular Melanoma Physician Task Force of Canada. And we will hear from Dr. Butler next.
Hi, my name is Mark Butler. I'm here to talk to you about current approaches in the management of metastatic uveal melanoma, and happy to be here and to answer your questions. These are my disclosures. The objectives are to discuss a little bit about how metastatic uveal melanoma comes about, to discuss various options for therapy, including first-line as well as treatment-resistant disease, to get a general sense of how uveal melanoma is managed. First of all, uveal melanoma is a rare type of cancer. About between 3 to 6 per million patients per year develop this disease. It is a cancer of the uveal tract, which is this the choroidal layer, which is part of the eye, behind the retina, ciliary body, which helps to increase or decrease and focus the lens, as well as the iris. This part of the eye has pigmented cells that can sometimes become malignant. Uveal melanoma is actually a disease which has multiple processes as it develops. Initially, it may start as a freckle, and there are standard types of mutations that are seen in these benign growths, freckles. But over time, some of these will degenerate where additional changes occur in the cell so that they develop a cancer. The uveal melanoma has two properties. One is to enlarge and grow and obstruct vision. And the second is the ability to spread. And those aren't always the same. So you may have a large uveal melanoma that doesn't spread to other parts of the body. That's called metastatic disease. But you can also have a small tumor that doesn't grow very fast locally, but spreads. trying to discern what type of uveal melanoma you might have will impact how physicians like Dr. Weiss monitor the patient. Uveal melanoma, as I mentioned, has several founder mutations, such as this first tier, GNAQ and GNA11. Those are also shared in non-tumors like freckles. These are very common mutations that can be targeted with medications. And then additional mutations may occur which are associated with the ability to spread or not. In terms of predictions, currently in Canada, there are two types of assays that people may have performed on their uveal melanoma at presentation. One is cytogenetics, and that's where you might hear the term monosomy 3, which is associated with a worse prognosis, or the Castle test, where a Castle class 2 is associated with a worse prognosis. Unfortunately, patients that have any stage of uveal melanoma can develop distant spread, which can result in patients passing away. But the larger the tumor, the higher risk of developing a relapse. The majority of patients with uveal melanoma will have liver involvement. In fact, 90% of patients at the time of presentation will have liver involvement, and half of those patients will have disease where only the liver is involved. Therefore, liver-directed therapy may be possible. This type of cancer, especially when it presents in the liver, can be asymptomatic for a long period of time. The liver is really good at hiding tumors so that the patient, when they begin to have symptoms, may have a large tumor in their abdomen, and that may need further attention. The way we are monitoring patients are with ultrasounds, MRIs, CTs, which are useful at identifying patients with large tumors. In contrast to standard melanoma, which usually is easily picked up on PET scan, uveal melanoma isn't quite as good in terms of how well it takes up the dye. So I don't personally use PET scans in screening patients with uveal melanoma. Unfortunately, for patients who develop metastatic disease, the survival curves are very disappointing. This is an example of overall survival in patients on clinical trials. But in recent years, we've seen some improvement in outcomes due to new drugs being developed. The types of treatments that are available include liver-directed therapy, and that includes surgery or ablating the tumor with either radiation or microwave treatments and other types of approaches, as well as liver-directed therapies where either radioactive beads or chemotherapy is administered. There's a new drug called Kimmtrak or tebentafusp. This has shown overall survival benefit. We use immunotherapy or immune checkpoint blockade, chemotherapy, palliative care, and clinical trials are options for patients. In terms of liver-directed therapy, it appears that patients that have a longer period of time before they present with metastatic disease seem to benefit more from the liver-directed approach. The tendency for these types of patients are that the tumor will not arise in new sites very quickly. So therefore, if we can get a regional control of the patient's tumor, they can benefit for a period of time. In patients who develop new sites of disease outside of the liver, you may want systemic therapy rather than liver-directed therapy for those patients. And as I mentioned before, there are different approaches. Either radioactive beads or chemoembolization can be used. In various investigations looking at liver-directed therapy, there have been several reports saying that liver-directed therapy is associated with better outcomes. But one of the challenges is that many of these studies are kind of mixed bag approaches, and there aren't randomized studies showing which type of liver-directed therapy is particularly good. Until recently, there has been some progress on that front. And that's the drug Heptazo, which is made by a company called Delcath. So you'll hear Heptazo or Delcath as a term used interchangeably. This also can be called percutaneous hepatic perfusion. Essentially, the way this works is that there's this machine which patients are hooked up to the machine, where the liver is perfused with chemotherapy and then taken out, and then the chemotherapy is drained from the liver and filtered through the machine so that normal blood is then returned. This has now been approved. It's commercially available in the US. Europe also has this approach, although the European sites are approved as a kit, whereas in the US it's approved as a drug. This approach has not yet been submitted to Health Canada. In the clinical trial, the FOCUS trial, patients were either treated with PHP or multiple different other approaches as their best active treatment. This included chemotherapy administered to directly to the liver, as well as other immune therapies. In the trial, they found that the chemotherapy, the chemo that was used was called melphalan, was able to prevent progression or prevent growth in patients' tumors, and to give them more time without tumor growth. And this also translated into a improved survival, additional few months, although unfortunately patients eventually do progress and pass away from the disease. So the most important thing to understand about the percutaneous hepatic perfusion is that it is approved in the US and in Europe, but the benefit is modest. On average, patients had a bit 4 months additional time, but it's not the cure-all for long term. The duration of response was about a year. So if you did respond to shrinkage of tumor, there was no additional growth during that time. And of course, this is of value for patients who have no other good option. And the other nice thing about this approach is that it is an approach that is long-lasting, and you don't have to receive additional therapy. As I mentioned before, there are mutations in the GNA11 and GNAQ genes, which results in the ability of the uveal melanoma to grow. Even though the freckle has the same mutation, additional mutations result in cancer being developed. But if we target these proteins and the signaling cascade that results from the GNA11 and GNAQ mutation, we can achieve benefit for patients, or at least that's theoretically what might happen. There are several different approaches to targeted therapy shown on this diagram. You may hear about a drug called selumetinib. This was a drug that inhibits a protein called MEK. In the clinical trial, standard chemotherapy was initially in a small randomized phase 2 study was compared to selumetinib, and there were increased responses seen with selumetinib, and this was felt to be meaningful, although the response, like percutaneous hepatic perfusion, was relatively brief. Then a randomized phase 3 study was performed. In this study, patients received the combination of chemotherapy and selumetinib at the same time, compared to chemotherapy alone. And unfortunately, the overall benefit was modest on this study, so that the approach with selumetinib is fairly limited in terms of benefit, and only patients who have no other good options will consider trying it. Another element of the uveal melanoma signaling cascade that's activated is a protein called protein kinase C. Darovasertib, or IDE 196, is a drug which poisons the protein kinase C molecule, and this drug has been studied in phase 1 and has now been looked at in phase 2 and 3 studies. What's been recently quite exciting is that darovasertib, which will inhibit protein kinase C, if it's combined with a second drug, which inhibits a molecule called MET, and in this case, the drug that's being investigated is crizotinib, you can see a synergy with these two drugs so that patients benefit. In this figure, you can see individual patients on lined up in a row here, where their tumors are change in the size of the tumors are listed, and there's a high percentage of patients, about 40 to 50% of patients will have shrinkage of their tumor on this combination therapy. So this has been very exciting for patients and for caregivers, and has been further studied in clinical trials. Here is an example where patients who receive the drug show decrease in the circulating tumor DNA with treatment with these medications. And this type of treatment has been durable in many patients. The darovasertib crizotinib study, or the IDEA 002 study, has now proceeded to phase 3, where patients are randomized to either the targeted therapy or investigator choice, which includes immune checkpoint inhibitor therapy like pembrolizumab or combination ipilimumab and nivolumab. In fact, the success of darovasertib has been so exciting that we're now using darovasertib alone in patients with localized ocular melanoma, large tumors. This is currently in investigation with the company, and Dr. Joshua in Australia recently conducted a small phase 2 study looking at patients with large tumors in the eye, where they received darovasertib alone, and a high proportion of patients had shrinkage of their tumors. This has resulted in 3/4 of patients being able to preserve their eye, as opposed to having enucleations, which in this case was what was going to be required for the patient's treatment. In terms of immune checkpoint inhibitor therapy, this is an interesting graph that demonstrates the difference between melanoma, where we see high responses and there are multiple mutations in the tumor, versus uveal melanoma, which has low responses to immune therapy, and also is known to have a low incidence of mutations. This is for anti-CTLA-4 ipilimumab, low response rates, and then single agent immune therapy, also low response rates in the 5 to 10% range. Significant more stable disease in patients, so it does have a role for some patients in controlling their cancer. Combination immunotherapy has a higher response rate, closer to 15 to 20%. And if you compare to historical controls, several studies have shown survival benefit with combination therapy. This is a Spanish study showing several patients who benefited with shrinkage of tumor, which would be durable in many cases. At MD Anderson, a clinical trial was performed, and the overall response rate was around 20% in patients receiving combination of ipilimumab and nivolumab. That's Yervoy and Opdivo. Other options for systemic therapy include a drug called tebentafusp. Tebentafusp is a first-in-class drug. It's the first time that a drug that targets a tumor using a T-cell receptor has been approved. This particular drug requires patients be positive for HLA-A2. So what is a tumor antigen? Multiple different types of elements of a tumor cell can be targeted by the immune system. In this figure on the left, we see different types of tumor antigens, like mutated antigens. There's a class of antigens called cancer testis antigens, differentiation antigens, in other words, antigens or molecules that are only expressed by certain types of cells in the patient's body. Viruses also can present unique antigens that the immune system can target. Tebentafusp targets GP100, which is a building block for making pigment. And then what happens in the way our cells process proteins in the body is that proteins undergo turnover. And the garbage man of the immune system, the proteasome, will chop up proteins that are undergoing turnover and place small little peptides on the surface of the cell that can then be recognized by the immune system. In this case, you have a CD8 T cell that's recognizing a peptide on MHC. What this involves is a way for the immune system to look for abnormal proteins like viruses, infections, or mutations, and also to look and say, yep, you're okay, you've got normal cells, normal proteins being expressed inside the cell. So what tebentafusp does is it targets this MHC molecule with the GP100 peptide with a drug called a BiTE. This BiTE recognizes the tumor cell in GP100, and then also on another side of the BiTE activates CD3 T cells. That results in a stimulation of the T cell that then targets and kills the tumor cell. So tebentafusp underwent analysis in 2 large trials. One was a phase 2 study with single arm, 127 patients. Another was a randomized study, over 300 patients were treated. What happens with tebentafusp is it recruits immune cells to the tumor, inducing activation. You can see all these colored lines are showing activation of the immune system. You can see immune cells in the blood disappearing and going into the tumor, and then with weekly treatment before each dose, that phenomenon stops happening. But in any case, tebentafusp recruits immune cells to the tumor, resulting in activation of these immune cells. And even in tumors that are very, very cold, in other words, tumors that have very few immune cells present, you can see increase in immune activation at the tumor site. And this in the phase 2 had some interesting results. First of all, there was a fair amount of shrinkage, 44%, but not a lot of patients had deep responses or shrinkage of tumor. It was only about 8% of patients that had a response to therapy. But when you look and compare to the historical controls, patients actually did pretty well. You saw better survival and a larger number of patients with slowing down of the tumor growth. A randomized study was then performed where patients received the drug. And again, we saw that the tumors maybe slowed down, but they didn't really shrinks significantly, only about 10% response rate, and the time to progression or tumor growth had some benefit, but not really a large percentage. However, overall survival was significantly better. Basically, patients live 6 months longer by receiving this weekly treatment. And there are some people that really kind of hit the home run where many years later they're still doing well. The drug has a lot of side effects at the beginning, but afterwards is very well tolerated. What's also interesting is that even in patients who had clear progression of disease, they seem to benefit a lot from the therapy compared to immune checkpoint inhibitor. So we think that this is related to slowing down tumor growth and allowing patients additional time without the tumor progressing and causing symptoms. In terms of who benefits more, it does appear that patients with smaller tumors have better benefit, and patients with larger tumors will have some benefit, but maybe not quite as much. Also, patients who have slowing down of the tumor growth will have better benefit compared to patients whose tumors just continue to grow with each successive scan. So really what we're having to do in the clinic is try to identify is who is benefiting from continued therapy. If we think that it's slowing down tumor growth, then we'll continue patients on treatment, even though the scans show that the tumors are bigger. In terms of sequencing, should we use immune checkpoint inhibitors like ipilimumab and nivolumab first or after tebentafusp? That is an area of discussion. We looked at our own patient groups. We did see some small improvement if patients started with tebentafusp first and then received immune checkpoint inhibitor. There's another group that looked at the same question, and they did not see benefit from Tebi first or afterwards. And we definitely did a review of patients receiving immune checkpoint inhibitors after tebentafusp, and the benefit of tebentafusp is associated with Tebi, not just with a sequencing from Tebi to immune checkpoint. In terms of side effects, a rash is very common, and something called cytokine release syndrome can occur in about 5% of patients. Although this is pretty well tolerated and a higher percentage of patients may have fever as the only manifestation of cytokine release. There are other agents that are being investigated, PRAME, for instance, early showing benefit in terms of treatment with a PRAME bite. That's also the subject of a TCR cell therapy trial. In terms of cell therapies, as most melanoma patients are aware, the U.S. has approved Iovance's Amtagvi, which is a tumor-infiltrating lymphocyte therapy. This is where a tumor biopsy is obtained. Cells are grown in culture and then infused as a therapy for patients. It's quite an involved process. For the clinical trial with Iovance, the time from harvest to infusion is about 3 weeks. This has been investigated in patients with uveal melanoma. The NCI back in 2017 published their experience. They saw about a 30% of response rate with this treatment, and several of the patients had durable responses with uveal melanoma. But currently, uveal melanoma durability hasn't been proven with standard TIL therapy, and it's currently not approved for uveal melanoma. There is a clinical trial with a company called Turnstone, where TIL are harvested, and then through a very complicated process, purified TIL are obtained and infused as a therapy for patients. This process, instead of 3 weeks, takes a few months. So patient selection is important in identifying appropriate patients for therapy. In terms of other approaches that are being investigated, there is a drug called SD101, which has been looked at as a liver-directed therapy to activate the immune response against tumor with a specialized treatment. So the company is called Trisalis. They perform a procedure where the liver is infused with a drug to activate the immune system, SD101. Patient then receives immune checkpoint inhibitor like pembrolizumab or nivolumab, and then patients are monitored. In their early phase trial, again, there was an improvement in ctDNA with dropping of circulating tumor DNA and an improved overall benefit in terms of stabilization of the patient's disease. Another approach that's currently being analyzed is a drug called RP2. RP2 is an oncolytic virus that requires direct injection into the tumor. The oncolytic virus is based on a herpetic virus. It encodes for an immune activation molecule called GM-CSF, as well as an antibody-like molecule that targets CTLA-4, along with GALV-GPR, which is a protein from viruses that causes tumor cells to basically fuse and then die. So this oncolytic virus has shown some encouraging results in patients with uveal melanoma. It's also been investigated in other types of cancers. But in the clinical trial, where appropriate patients were identified, injections of tumor could result in shrinkage of the tumor, as you can see here, as well as decrease in the size of tumors that are not injected. And again, shown here on MRI, benefit of treatment with this approach. So in summary, uveal melanoma is a rare cancer. It has unique molecular and clinical features. Therefore, targeted therapies, immunotherapies, liver-directed therapies offer hope. Tebentafusp has been approved and can provide meaningful benefit. The future, therefore, is bright with new therapies on the horizon, with liver-directed therapies, targeted therapies, and cell therapies. Thank you very much. Happy to take some questions now.
We have a series of questions from patients, and the first one is about clinical trials. Are there any new trials on the horizon that include patients who are HLA negative?
Well, currently, for patients who are interested in receiving treatment with darovasertib and crizotinib on the IDEA study, only patients who are HLA-A2 negative are eligible, and it is only available for patients in the first-line setting. So that's a study that's currently accruing. I believe it will continue to be accruing over the next year, and patients who are appropriate for this study are patients who have not received any other systemic therapy, and also patients who have not had any radiation to the liver. patients who have had surgical procedures or some ablative procedures may be considered for those for that study. In terms of HLA-A2 patients, the darovasertib crizotinib study currently does not have any slots, but there's expected to be slots for a period of time in early 2025. I think there will be a limited number of slots. The main hope is that we have a positive result so that patients can access these drugs on a compassionate basis.
Thank you. Here's the next question. Could you provide any updates on the TIL trial and what its impact on treatment for metastatic uveal melanoma might be?
Currently, the Turnstone study is identifying patients with uveal melanoma for that study. It's been on a pause over the last 6 months, but it's expected to activate again. This is a study that is limited to patients who've only had a couple of lines of therapy. So if a patient has had multiple different lines of therapy, they may not be eligible for the TIL study. I think it's also important to understand that the Turnstone study or T-Bio study takes quite a while for generating the product, and therefore patients need to be carefully selected.
Thank you. And another question. What are the latest developments on Replimune and injecting viruses into liver tumors?
In terms of Replimune, for patients with uveal melanoma, a study has just been opened. It's accruing patients in the United States with 3 sites. It's expected to expand to Europe as well. It's called Replimune is the company, and RP2 is the drug. The company is being courted to open slots in Canada. We're really pushing and hoping that that will happen. And certainly if anybody has any ties with the company, it would be great to get this agent. It's very promising to our Canadian sites.
And another question about liver treatment. My understanding is that PHP procedures are currently unavailable in Canada due to resource limitations. Could you provide insight on this, please?
In terms of liver-directed therapy for PHP procedure, currently this is a treatment that's not approved in Canada yet. Although we have been discussing with Delcath to try to get them to submit for approval at Health Canada. It is available in the US as well as Europe as a therapy. And unfortunately, we don't know whether we can get this approved for coverage by provincial payers, although in appropriate cases, we can at least try to see whether that's possible. I have been in discussions with the company about bringing this therapy in terms of a clinical trial to Canada, and we're working on that.
Thank you. Next question is also about liver treatment. Are there any ongoing evaluations of histotripsy, particularly its effectiveness for liver tumors? Is there potential for this technology to be adopted in Canada, including IR training and equipment access?
Histotripsy for liver tumors, this is where patients with tumors are treated with ultrasound waves. This is an area of intense research, and hopefully we'll see progress with this technology in the future.
Thank you. Next question. Are there any treatments for metastatic uveal melanoma approved in Canada besides Kimmtrak? Or are there any applications for new approvals actually in progress?
In terms of approvals, right now there is some variation in practice. Patients in many of the provinces who are HLA-A2 have access to Kimmtrak or tebentafusp. After treatment, there's some variation in terms of what immune checkpoint treatments are available, either monotherapy with anti-PD-1 or combination with ipilimumab and nivolumab, and discuss with your treatment team what options are available to you.
Thank you. What are the available options for patients once Kimmtrak becomes less effective?
In terms of the what treatment options, additional treatment options patients have for after Kimmtrak, one of the approaches that many of us will use in addition to monitoring patients and speed of tumor progression is look at adding some local therapies while we continue the Kimmtrak. This includes radiofrequency ablation, where microwave treatments are used on a tumor that's growing when several other tumors are shrinking or stable, as well as radiation approaches.
Thank you. And the final question, where does Canada stand in comparison to the US and Europe regarding treatment options? It appears that other countries may have more treatment alternatives.
I think in general, we're actually doing pretty well. There's a lot of focus on the things we don't have. However, I think we should also be aware that there are things we have that others do not. For instance, up until recently, Kimmtrak has not been approved in the UK. It's not available in the Netherlands, whereas we have had it for over a year, and we've had a generous, compassionate program for Kimmtrak. So this is important to be aware that we have options and treatment therapy options. We also have a reasonably robust clinical trial program, although as is important to be aware, unfortunately, this is a rare cancer, and therefore patients have to travel a distance to be able to benefit from treatment. I am proud to say, however, that we've been a lead accruer with the darovasertib studies, the neoadjuvant study, as well as the metastatic study, where we're able to treat patients. And hopefully this history will encourage other companies to come to Canada, where we can conduct high quality, excellent clinical trials to benefit our patients. So with that, thank you very much. I really appreciate the time to talk with you, and look forward to further interactions in the future. Thank you.
Thank you so much, Dr. Butler, for such an informative presentation. We truly appreciate you taking the time to provide a detailed and comprehensive overview of metastatic disease and the current advancements in the field of ocular melanoma. We particularly appreciate your patience with our many questions. Sadly, our next speaker, Dr. Ezekiel Weiss, couldn't join us today. As you know, these amazing doctors are often performing what feels like magic, and he couldn't be pulled away from his important work. But don't worry, Dr. Weiss has recorded his presentation, and everyone who registered will receive a link to watch it. It will also be available on the YouTube channel and website. You'll see references to those at the end. Those presentations today were fantastic. I want to extend my heartfelt thanks to Dr. Butler, Sherry, and of course, John, for taking time out of their busy schedules to share their knowledge and experiences with us. I also want to thank every one of you for attending the symposium and being part of the incredible community of ocular melanoma patients and caregivers here in Canada. Seeing so many of you come together to learn about this disease truly gives me hope. Don't forget to join us tomorrow at the same time for day 2 of the symposium. You will have an opportunity to participate. We have an exciting and packed agenda, and I'm looking forward to seeing you all then. Take care and bye for now.